Hi, and welcome to another edition of the SITREP. Today's subject is going to be shingles, and with me today is Dr. Sarao. How are you?
Thank you for having me.
And would you give us your title, please?
Yes, I'm a clinical associate professor of medicine at Boston University and instructor on medicine at Harvard Medical School, staff physician at the VA, principally located at the West Roxbury campus.
So just one hat after the other,
Yep.
like we all do now.
Variety keeps it exciting.
There you go.
Yeah.
There you go. Before we get started, how about hitting that like button and subscribe so you can stay up to date on all things SITREP? Okay. So let's get into this. Let's start with the whole thing. Shingles, I've had it. I loved it. No, not at all. What is shingles? What's our definition here?
So shingles is the colloquial term for herpes zoster. Herpes zoster is the scientific term for a virus called varicella. And it's a unique infectious disease because it's essentially a clinical presentation of a reactivation of chickenpox. And so in general, in its simplest term, it's characterized as both a rash that occurs along a certain part of the body, typically along what's called a dermatome, so a specific nerve root, associated with what's called neuritis, which is medical terminology for the nerve is inflamed. So in short, typically a painful rash that is occurring in a band-like distribution.
Caused by chickenpox alone, or is it?
Pretty much, yes. Okay. So it's specific terminology used for the chickenpox virus that I don't know if the audience or many people know this, but certain viruses that humans get infected stay with us for life. Mm-hmm. Chickenpox is one of those. And so what does it do when it's in your body after you've had chickenpox when you were younger is it hangs out in the sensory nerves and it just sits there for decades until it can have the opportunity to emerge. Principally, the short answer is the older you get, the more you tack on issues that can affect your immune system, it has the opportunity to break out again.
I gotcha. So if I've never had chickenpox as a child or an adult, can I still get shingles?
Short answer is no, you can't. However, if you've never had chickenpox before, you can certainly still get chickenpox as an adult. That's not a scenario one would prefer to have, principally because most infectious diseases of this nature, childhood illnesses, tend to be milder. And so if you happen to be an individual who has never had the primary chickenpox infection, you're not going to get shingles, but you can get chickenpox as an adult. Chickenpox as an adult is no picnic.
No, I bet. Well, shingles is no picnic. So I get the feeling it's about the same. Okay, so, and you said it presents itself, like, and I'll use my own experience. When I had mine, it presented itself right up there. I had no idea what it was. I was young. I thought I was just simply breaking out like a 16-year-old going to prom or something.
Yeah.
And it started, and it just got worse and worse each day until it came into my eye and elsewhere. Yeah. So how does it normally come on? Is that?
Yeah, I like the way you say the term present itself because some infectious diseases are not very specific. You know, I feel fatigued, I have a fever, I have a sore throat, a headache. This one is unique, but sometimes people don't notice it until, oh, it's getting worse and now I see something. So the classic presentation is I have some numbness, tingling in a band-like distribution. And the reason why it's band-like is because the nerves of our body basically spread out from the cranial nerves or the spinal cord into nerve roots that innervate or supply sensation and motor function to portions of our body. The type of shingles that you had was called V1 zoster, herpes ophthalmicus, which can also involve the eye. And so sometimes people feel like a little numbness or tingling in that location. The most common location is thoracic and lumbar. So people may feel this kind of itching, tingling, numbness, burning. But if a patient presented themselves to me that way, I would ask, is it kind of encircling more or is it just local? Mm-hmm. It could start local, but then if the patient starts to say, I'm feeling it like it's starting at my back and it's coming across, even if there's no rash, a rash will more than likely present itself in about 2 to 3 days after that initial sensation. Mm-hmm. We've had patients over the years that I've also clinically seen who come in with chest pain and they have cardiac risk factors and you're like, is this angina? Is this a heart attack? Until it begins to declare itself as, no, they're very sensitive to touch along the skin. And then you begin to see the rash that pops up.
Okay.
So it's kind of insidious in that way.
Interesting.
For most people. But it varies in severity. Some people can have the worst pain that they've ever experienced. And some can have milder versions. Yeah.
So you're kind of already talked about them, but there's symptoms. Are there other symptoms other than the band starting, or?
Yeah. So depending on the host meaning the person who's getting it, when you're younger and you get shingles, in general, it's a milder version. When you're older and you get shingles, and let's say you tack on chemotherapy or you're severely immunocompromised, the more probability that symptomatology and the way it presents itself can be more extreme. When you're vaccinated, that basically aborts a lot of the severity and the presentation. But the initial signs and symptoms, again, tend to be sensory, meaning numbness, burning, tingling. Think of it like if you've ever cut your finger and then it feels like it's never quite, it's always burning and tingling. It's that kind of sensation. Many patients with diabetes have similar type of sensory symptomatology in their feet. They always describe a sensation of walking on pins and needles. Yeah. It's kind of that similar thing. Now, if it tends to be localized shingles, then most people don't have fevers, chills, night sweats, none of that. They may just have the localized symptomatology until the rash is there. I made a distinction between mild cases, which sometimes people may not even notice, and it's a very mild presentation, to severe cases. As clinicians, we always have to determine, is this a mild version, or is this something that could compromise vision, or is this something that is disseminated? Because if the immune system can't control it, again, remember, it's a reactivation of a virus that the body has already experienced. And so it's contained to some extent, but in advanced HIV patients, in cancer, chemotherapy, advanced diabetics, you can not only have the rash present here, but it can almost manifest as chickenpox again, meaning the virus has broken through and now it's everywhere, including the respiratory tract.
So are there stages then? I mean,
yeah,
kind of we're flowing through this, but it's, stages. In other words, I start to feel a tingle.
Yep.
And then some blisters start.
Exactly. So on average, 1 to 2 days of the prodrome, which can be sort of that sensory type of symptomatology without a rash, it can signal to the patient and the clinician, this could be shingles. I don't see a rash yet, but maybe there will be. The rash will, in general, develop unless you're vaccinated or have a robust immune response that you prevent the rash from occurring. But the next stage is the rash. And the rash itself presents very closely to the stages that we see in chickenpox, but it's only along the nerve root. So there's this dermatology type of terminology that we use as clinicians. There's macular, papular, vesicular, pustular, and then crust. That's the gradual progression. In lay speak, it looks like a little red non-raised area that becomes sort of a bump, and then it becomes sort of a blister. And the blister is what we call vesicular. That appearance, the vesicle in lay speak, it looks like a dewdrop on a rose petal. It's kind of this underlying redness with this little blister that's there. When those start to form along a band, then particularly if they start to look bloody, then that's the natural evolution of this. When those things ultimately pop and or start to heal, it's very similar to the way we scrape our knee. Once it starts to crust over or scab over, you're now in the healing stages.
I got you. So, and then we talked about, like, mine was in the forehead and worked its way down. Dangers being the eye, of course.
Yeah.
So you don't want to wait for that to crust over and do all that. I'm going to go where for something like that. I mean, I guess I'd go anywhere if I got it on my side or anything. But when we talk about the dangerous side of it.
I think what you're alluding to is, when should I be worried or when should I seek medical attention?
Yes.
In general, if an individual develops thoracic or lumbar, meaning it's occurring below the neck to above the waist, and it just stays there, At its best, it's a mild tingly rash and it heals. At its worst, it's a rash that now leads to a lot of pain. But when shingles misbehaves or compromises things, if it's near to the central nervous system or the brain or the eye, the one thing that as clinicians, if we ever see what's called V1, which is cranial nerve 5 that offers sensation to the face, if it's involving this area in the upper portion of the face, that can involve the eye. And so it can involve many sections of the eye. Long story short, if it's untreated and it is involving the eye, then vision loss can occur, or some portion of vision loss in 50 to 70% of individuals.
Wow.
So any shingles, any numbness or tingling, followed by rash in this area should prompt patients to seek medical attention pretty fast for that one. For other areas, it depends on the severity. By all means, there's no reason to not seek medical attention because there are therapeutics that are involved as well.
All right. Contagious? Should I stay out of work for a couple of months?
No, not a couple of months.
Damn.
So it is contagious, but less contagious than chickenpox.
Okay.
Chickenpox, same virus, but chickenpox is a widely disseminated infection that's breathed out. And so that is highly, highly, highly contagious. If you have a room full of 11 people, one of them has chickenpox, 9 out of the remaining 10 will get it. It's got what's called a high attack rate. Now, shingles, it's a reactivation, but it's more of a contained version of that infection. So you're in general not transmitting it by breathing. Breathing tends to be problematic because we're talking and we walk past people and it can get into our eyes and nose and so forth. Shingles is less contagious. So best case scenario, if it's in your thorax and you have a shirt on, you are very, very unlikely to transmit that to others, because what is communicable or contagious is the actual blisters themselves. So you want to avoid touching those or having somebody touch them or have them pop, which sounds kind of gross, and kind of aerosolize a little bit of that. The moment they are crusted over, or the moment somebody is on systemic intravenous therapy, typically by 24 to 48 hours after crusting has occurred or you're on treatment, the contagiousness drops way down. So when are you no longer contagious? The natural evolution, we're talking on average of about maximum of 2 weeks of this whole process from the original tingling. The time of contagiousness is when the vesicles, the little blisters start to pop up, particularly when they're popping and bleeding, to the time that they crust over. And that's in general 7 to 10 to 14 days. And then you're done.
Gotcha. All right. Hereditary?
No. No, the not hereditary, except to say risk factors for acquiring it. There's no genetic predisposition, but are there genetically mediated diseases that increase one's risk? If you have a family history of diabetes, are you in general more likely than not to develop shingles? The short answer is yes. So it's a lot of the risk factors for developing shingles are acquired immunodeficiency states. But the top reason for developing shingles is something none of us can avoid, is getting older. So age 50, it starts to increase. 60 by on average of about a quarter, 25% or so of people will develop shingles. By age 85, 50% of people that are not vaccinated will ultimately develop shingles. Wow. So age is the number one. In clinical practice, most of the folks that I see develop shingles are those that have not benefited from the vaccine or are critically ill for other reasons, cancer, chemotherapy, and then it pops up as part of that clinical presentation.
And you say 50 and older, but it can happen to people younger than that.
Yes. Yeah.
So, as I can attest to.
Yeah. And it's unusual for young people to have it, but why is it occurring? It's in general, the immune system has many different reasons why it may not be able to contain the virus that's hanging out in the nervous system. And so sometimes physiologic stress, emotional stress, because it alters cortisol and other hormones in the body that impact the immune system, could cause it. It's a rare cause. When a young individual presents with unusual infectious diseases, it's always worthwhile to explore, could there be a new diagnosis of diabetes? Could there be a new diagnosis of other immunocompromised states? But I don't want to worry the audience by saying, oh my God, I got shingles when I was 25. Do I have some underlying bad disease? Not necessarily. But it is more unusual when you're younger. It's commonplace when you're older.
I see. And then I can get it more than once though. So now that, I know that myself, I still get it almost annually, if not twice. And I notice mine, it's stress related, which I know is a big piece of these. If I go into a project that's driving me insane, I mean, it was when I was in the military, it was the same way.
Yeah.
And even now in life, if there's certain stressors involved, I can feel that coming and I know.
Yeah.
But also sunshine.
Yeah. So you raise an interesting point because a similar infection that presents that way is cold sores. Varicella zoster, the virus that causes chickenpox and shingles, is a herpes virus. It's one of 8 herpes viruses. Herpes simplex virus 1 and herpes simplex virus 2 are the common herpes infections that we think of. Sunlight, UV radiation, stress, chapped lips, etc., are very common for cold sores to pop up. Shingles has some of that occurring. In general, what happens when the virus breaks through in somebody who gets shingles is the immune system recognizes it again. And every time it does that, it has a slightly better chance at controlling it and preventing recurrences. But it's not unusual to get recurrences. However, it isn't the common presentation for most cases of shingles. It's usually a one and done. But again, as we age, as new things occur to our immune system, can that virus pop out just like herpes can pop out? Herpes is a virus that stays with us, and it certainly can.
Yeah, we got to come up with a better name when they say it.
Exactly.
Is there a test for it? So in other words, if I've got it in my system somewhere, can I go to the VA and say I need I don't want to say herpes test.
Well, if you say it, and then we can kind of tease out what's going on. The test this is an infection that is predominantly clinically diagnosed, meaning if we were out in somewhere where there was no laboratory, no hospital, and you're describing symptoms to me, and then I see a rash, do I need any additional testing? No, because it is the word prototypical or pathognomonic, meaning pathognomonic means that it is so specific to shingles that the diagnosis can be made without any ancillary testing.
I see. But
confirmatory testing can be useful for presentations that are a bit unusual. For presentations in which one needs to gather more refined data to adjust therapies, et cetera. I take care of some patients who develop resistance to typical antivirals, and so we have to use more hard-hitting type of agents. And so testing for it, if a patient presents to an emergency room with a classic shingles rash, they don't necessarily have to expect that they're going to be getting blood tests and other things because it can be done simply by looking at it.
I see.
And that's pretty close to, it's not quite, nothing is quite 100% accurate when it comes to clinical presentation, but it's so classic that that's the way the diagnosis is made.
I see. And catching it early, I mean, in other words, is there a way to, well, I guess if there's no real test other than looking at it, so as far as catching it early, if I start to see something breaking out on me, if it's bothering me that way, then I should be coming in and probably getting checked.
Great question. And the reason why I say that's a great question is that if there's a suspicion that shingles is brewing, the sooner you use antiviral medications, if that's going to be part of the treatment, if you start those within 72 hours, you have a better chance of controlling it, particularly acute pain and maybe some improvement in downstream complications. If you wait too long, so let's say you have the rash and it's been there for 3 days, then getting diagnosed at that point in time has less of an impact on what clinicians can offer patients. The only problem is that when a patient presents and there's no rash, but there's a sensory nerve distribution, it may be a scenario in which I've been involved in cases like this where I have prescribed acyclovir or valacyclovir as a pill. But I would tell the patient, keep looking at it. And if you start to see any rashes, then start taking it. Because you don't want to take a medication for sensory burning, tingling that ultimately isn't going to be shingles if it isn't shingles. But the sooner one seeks medical attention, the bigger bang for the buck, so to speak, for the treatments that can be offered.
Gotcha. Is there anything I shouldn't do if I've got shingles? In other words, don't scratch the...
Yeah. So the most common complication of shingles is this condition called post-herpetic neuralgia, which is independent of what you do. It's dependent entirely on the severity of the initial presentation and the interplay between how the virus is affecting that nerve. But for secondary complications, yes, avoid scratching because another complication, particularly in the elderly, when their skin is more friable, their immune system is weaker. If you have a rash that's totally macerating your skin, it's sort of like road rash or a rug burn. That's a setup for our own bacteria to create secondary cellulitis or bacterial infections, which we can see quite often.
Yeah, I can believe that.
So you want to keep it clean, dry, use a dry, sterile dressing, and then avoid scratching. But scratching and itch is not as profound in shingles as it is in chickenpox. Chickenpox can itch like crazy, and that's where the scratches can occur. In this scenario, itching can occur as it begins to heal. So at any stage in time, yes, it's important to not scratch. And one of the ways to prevent that from doing that is just keep something over it. Yeah.
So I know of a lot of people who have had it because I'm older now, so I know older people, and as well as myself. It was about the pain. I mean, it was. I mean, I've met people that can't sleep at night because they can't roll over on that side. For me, I couldn't sleep on this side of my head.
Yeah.
So that's a big piece of it. What's our treatment?
So treatment for the primary shingles rash includes antiviral medications and some of the drugs that people may have heard of, acyclovir, valacyclovir. Those are also commonly prescribed for primary treatment or secondary prevention of cold sores, herpes infections, genital herpes, etc. Same drug. It works the same for both. And then there's also famciclovir, and then there's foscarnet, and all these other drugs that, as an infectious disease clinician, we sometimes use if there's potential for breakthrough or resistance. But the number one treatment that most people seek attention for is, doc, this is hurting like crazy. And I had mentioned earlier that I was one of the principal investigators for the earlier shingles vaccine. And one of the things that we were looking at is, could the vaccine prevent post-herpetic neuralgia, which is the pain that's there? And so in that study, we noted that the presence of the burning sensation is drastically reduced with the vaccine. So the one thing that I'm mentioning is prevention. Prevention is key in actually reducing that. But for folks that have breakthrough shingles or were never vaccinated, when they're seeking attention for the pain, then we're using a variety of different medications. In the acute stages, non-steroidal anti-inflammatory like Motrin, ibuprofen, because it's very inflammatory. And then you're using narcotics. And so when you're using narcotics, as we all know, opiates, oxycodone, OxyContin, those are how shall we put it? Those we want to use with caution.
Sure.
And particularly as people get older, those can lead to constipation, delirium, confusion, addiction. So if we can avoid that, then you can basically prevent having to use that. And then I've treated patients, and the literature shows that because the nerve is irritated, we use these classes of drugs that work for neuropathic pain. Gabapentin, tricyclic antidepressants, classes of drugs the general population may or may not be aware of, but they're intended to calm the nerve that's irritating or that's irritated. The point I wanted to make earlier is, that the pain in post-herpetic neuralgia, the nerve that's irritated for weeks to months to maybe even years, affects the quality of life of people as severely as other major chronic illnesses. And so it is, for people that have had it, they say, I wish I had the vaccine, because they are left with a quality of life factor that rivals other chronic illnesses. I don't know the exact statistic, but there were a number of studies when we published the results of the shingles vaccine that compared the severity of shingles pain to childbirth or other things. And it kind of ranked it in certain, and it's up there. It's really high. So patients come to doctors because they're like, this pain is horrible.
Yeah. I felt like somebody punched me in the face.
Yeah.
And it just continued to hurt for, mine was a couple of weeks before it finally started to settle down. And then, like I said, I still get I still have the tingle up there, and it feels like it's always bruised. But it's, I've been able to handle it with valacyclovir.
Yeah.
So that has been my medication for, I don't know how many years now, forever it seems. And it's also, as you've said, it's kept the cold sores away from me too, which I've always been thrilled with. Are there any side effects to the medications? Or the shot?
So let's talk about the vaccine. There have been 2 vaccines. The first one was Zostavax, which I was involved in, and then the subsequent one is Shingrix. Zostavax is no longer in the market simply because even though it was effective, it wasn't as effective and didn't produce sustained efficacy or sustained results. Shingrix is the newer one. And the reason why I'm mentioning these 2 is because they have their fair share of side effects. In general, vaccines are, for the most part, very safe. But the original vaccine, the problem with that one is you couldn't give it to individuals who had weakened immune system, because that is a live attenuated vaccine. It was essentially a boosted version of the chickenpox vaccine, but because it's live attenuated, if you give it to an individual who's got a weakened immune system, you run the risk of developing a mild version of the disease you're aiming to prevent. Shingrix is the newer one, and this is a recombinant vaccine that is not live, and so you can give it to anybody, but the thing that makes it a little bit more unique than others, and I say this to my patients, is this one is a little bit more than the other ones where you can get soreness at the injection site. But it's not enough to prohibit its use, and it's been around for several years now with a pretty good safety and tolerability profile. So just like any other vaccine, the number one side effect from any vaccine is injection site reactions. And Shingrix is the one where I've had some patients who go, I felt nothing. And then others who go, wow, that hurt for like 24, 48 hours. Wow. But they were like, yeah, I came through it. And but the efficacy of the vaccine, speaking of its comparison to its predecessor, is substantially better. So we're literally reducing the risk of ever getting shingles. It's a 2-shot series, upwards of 80, 90, 95%, and the risk for post-herpetic neuralgia, the really painful rash, or the painful sequelae, by 80%. So 24, 48 hours of a sore arm versus preventing, oh my God, I'm having months of this pain and I need narcotics and I need to take medications that also have their side effects. If you can avoid that, that's the benefit of that.
Yeah. And so 2 shots done forever and ever?
2 shots done.
And I will never say you can never get it again, right? Or is it?
Can you get shingles?
Can I still get shingles? I mean,
you can. So are there vaccines that are 100% effective at preventing a disease to ever occur? The short answer is no. The vaccine is intended to have your immune system primed and ready to go to abort the infectious process from taking hold and wreaking havoc. So the short answer is, given how effective it is, you're dealing with a small percentage of individuals who can still have shingles, but it's attenuated. So when I was involved in the shingles prevention study, the VA Cooperative Studies Program back in the early 2000s, we evaluated patients coming in that were blinded to did they get the vaccine or did they not get it. And there were individuals who had mild tingling and one pimple here, one pimple there. And we presumed they probably got the vaccine because it looks like shingles, but the patient's like, I don't know, what do you think, doc? Is it shingles or not? And we confirm by testing for it. Long story short, when people do get shingles after they've been vaccinated, the vaccine works so well that it presents like it's nothing. Okay. So it's a very, very mild version, if at all.
Okay, that's great. And we were talking about this earlier. It's the VA's research
correct.
that led to this vaccine, correct?
Yes, the very first one, Zostavax. And so that was multi-center, also co-funded by the pharmaceutical company Merck at the time. It was a randomized controlled, placebo-controlled trial looking at vaccine recipients versus placebo recipients and determining over time who develops and who doesn't develop shingles, how severe is it, what are the downstream benefits of if you receive the vaccine with respect to the painful symptoms that can linger. And at that time, it was approved and it was in widespread use and it worked, but not 100%. And so companies developed additional versions of this. And so the current one is, I'm not entirely certain where the current one, where all the studies emerged from. I was not involved with that. Yeah.
But Shingrix is the latest flavor of the week.
It is.
Okay. All right. Are there different types of shingles? I mean, is it just one style? And I mean, like we've talked about different places it can be, but
it's principally the best way to categorize different types of shingles is it uncomplicated or complicated. And we make that distinction because uncomplicated sounds like what it sounds like. It's boring, it's mild, it's not a big deal. Complicated, if I see a patient who walks in the door who has a presentation of a rash here, but then I also notice another vesicle, the little blister here, another one here, another one here. That's an individual whose immune system is unable to control that virus. And so they are more prone to having systemic manifestations, including things such as confusion, infection of the brain, infection of the spinal cord, involvement of other organs, including the lungs, the eyes, etc. Those are scenarios in which require hospitalization. Those are not the common scenario, but that's the most extreme version. And again, the other types of manifestations of shingles that the audience should probably be most aware of, as we talked about, is it in a physical location that even though it isn't bothering you too much, but it's close enough to the eye, an ophthalmologist or an optometrist needs to get involved to ascertain, is it involving the eye? And if it is, then the treatment typically requires intravenous therapy because you really, really want to get rid of that virus to prevent blindness.
I gotcha.
Yeah.
So should I get vaccinated? That's
yes, you and me both.
right. Now I'm thinking about getting rid of the pill and going to the vaccination. That might be the route now.
Yeah. So vaccination itself is not necessarily treatment for shingles, and it isn't. It's intended to prevent. You're kind of in a unique scenario, and the question is, will a vaccine reduce the recurrences that you're experiencing? It may, because what it's doing is it's further bolstering your armamentarium to kind of control it outside of what your own immune system is doing. So it's always advised, certain vaccines are required for school. Certain vaccines find their way for public health implications. This vaccine, in looking at its impact on the individual and healthcare utilization and costs, is quite impactful. So can individuals not get it? The recommendation from the American College of Immunization Practices, it's preferable to start at age 50. Some can delay it until 60 because as you age, the probability is higher. So what's the benefit? The benefit is prevention, pretty darn close to not 100%, but much better, of ever having to have this phenomenon occur.
I see.
Yeah.
I see. So to recap, I start to feel something, maybe a band, or I start to notice the blisters. I should probably seek help. Should probably get the shingles shot.
Yep.
at the age of 50 and beyond, or when I find that I've got this.
Yeah.
And then just follow my doctor's advice. So, I mean, I should just come to my PCP to start with if I feel like there's something going on here.
Yeah. I would flip that a little bit because the discussion in general, if you're 50 and above, would be, hey, you're due for the shingles vaccine. I think it would benefit you. Let's get you set up. And just like the chickenpox vaccine, when I was a kid, everybody got chickenpox. Now you hardly see it because it's sort of a victim of its own success that it's basically preventing chickenpox. So the downstream benefits, if the conversation I have with you is instead of, oh, you've got a rash, let me assess what it is and let me treat you for shingles, is I have a conversation with you, let's give you the shingles vaccine. So 20 years from now, we never have a conversation about you ever getting shingles. So it's a preventative approach.
I like that. I probably should have gone that route myself. So anything else you want to add to this that we may not have covered?
The only thing I would say is I'm highly an advocate, as most physicians are, for vaccination, simply because the downstream benefits is that it benefits the patient and then it's also limits complications. So I'm a hospitalist and an infectious disease physician where I see predominantly hospitalized individuals. In the cases that I see of individuals who present with shingles, I look at it and I go, that could have been prevented. And same goes for a variety of other things. So if I were to say anything, just like wearing a seatbelt or whatnot, vaccines are just so effective at preventing a discussion like this that we no longer have conversations about polio in this country. And we rarely have conversations about measles unless it's emerging at Disneyland or somewhere else, or pockets of such. And so it benefits the community, it benefits the patient, it benefits downstream complications and the need for other therapies. That when I have a 80-year-old who develops shingles and I have to prescribe hard-hitting narcotic pain because the pain is so miserable, it just gets messy. And so if that's entirely preventable, then it's preventable. Yeah.
Well, thank you. I appreciate having you on here today, and I appreciate your knowledge and your advice. So there you have it, folks. If you're thinking about it, stop in, see your PCP, make that appointment, and get that Shingles shot. It's 2 of them. It's going to start to prevent all these issues. Why not? For those of you who haven't done so already, please hit that like and subscribe button so you can stay up to date on all things SITREP. Other than that, thanks for tuning in. We'll see you next time.
Hey folks, connecting with your benefits is our primary mission, and the SITREP is providing more options than ever.
Subscribe to our free email newsletter, subscribe to our audio podcast channel, or subscribe to our content on YouTube.
For details and links, check out the description below.